So evening, thanks all for joining us. My name is Fiona Lebroy from Heartburn Cancer UK, and I've got my colleague Jess here who's been communicating with you all to give you the registration details for this evening. And I'm delighted to welcome Professor Anthony Hobson, who's the clinical GI scientist at the Functional Gut Clinic. And we're delighted to have Anthony with us this evening to give us an expert speaker talk. Tonight, we're going to be talking about the role of gut bacteria and diet when reflux medication doesn't work. So very topical. We get lots of questions about this. So lovely to have some expertise on that from Anthony tonight. There will, as ever, be opportunity to ask questions as we go along. And in terms of housekeeping, for those of you who've been with us before, if we can have your microphones on mute, that's great. And if you want to ask any questions, you can either raise your hand or put any questions in the chat. And we will circulate the recording and any key takeaways from this evening probably sometime next week because of the Easter weekend, and for anybody who hasn't been able to join us this evening. I will just ask, for those of you who are not showing your camera, you don't have to, but I always think it's really nice for our speaker, if there are a few faces, he can just sort of gauge the crowd, so to speak, and see if anybody's wanting to ask questions. So if you're happy to turn your cameras on, great. If you don't want to, that's fine too, but if you are able to, that would be smashing. So without further ado, I think I'll pass you over.
Thanks very much, Fiona and Jess, for inviting me. Can you hear me okay?
Yep.
Okay, great. So welcome, everyone. I'm very excited to come and give this talk tonight. Let's give you a little bit of background about our clinic. So I've been working in the field of reflux since 1991 when I started as a student with John Bancevich, who was an upper GI surgeon in Salford. So I've been doing this quite a long time. And in 2014, I set up a clinic in London. We now have clinics in Manchester and Cambridge as well, so that we could really focus on GI physiology and understanding how the gut functions. And in particular, interest for us was to try to identify what causes reflux in patients, what the best treatments are, and how we can provide the best evidence so the outcomes for those patients are the best. So we test about 4,000 NHS and private patients a year who have reflux, so quite a lot. We do a broad range of other gut health tests that provide complementary information to all of that. Let me just move this down a little bit, sorry. And really our mission is to provide the highest quality gut testing for all patients so that the cause of symptoms is identified and the correct treatment is applied, rather than just treating people empirically. And there's a massive unmet need. Just looking at the people who have reflux in the UK, prevalence is estimated at about 8.5 million. About 5 million of those people are on acid suppression, but only 3 million consider their symptoms controlled. So we have another 5 million here of inadequate response to medication, or who are untreated and are just relying on lifestyle medications. And this has a big impact on quality of life. The problem for most clinicians is that people don't really present with a diagnosis, they present with symptoms. And these are the most common symptoms that we see. So everything from heartburn, regurgitation, diarrhea, bloating, abdominal pain, dysphagia. And quite a lot of people who present to us have a mixed bag of symptoms. So people who've failed conventional medication, who still have these symptoms, what we need to be like the Sherlock Holmes of GI. And we need to try and figure out what's causing those symptoms, which symptoms are most important to people, and how we can be effective in differentiating and treating them. And I first want to just introduce this concept of the brain-throat-gut axis for reflux. It sounds quite grandiose, but really what I'm trying to say is that from top to bottom, from the brain all the way down to the colon, everything is linked together. It's like a bidirectional railway of information going backwards and forwards. So the brain influences the midgut influences the stomach and the brain. So all these things are talking to each other. So when we're considering a reflux patient, rather than just focusing on the esophagus and the stomach, we always try and consider all of the other things that might be contributing to reflux. So this is your traditional diagram of reflux, just showing that there's liquid content in the stomach. When the lower esophageal sphincter relaxes at the bottom of the esophagus, then contents come up. That's quite normal for most people. But if that becomes excessive in people with a weak sphincter or a hiatal hernia, then you can get things like esophagitis, so inflammation in the esophagus, and Barrett's esophagus. The most common causes of this are slow stomach emptying, hiatus hernia, excessive relaxations of the sphincter, poor esophageal motility. And most patients are initially trialed on anti-reflux medication, either antacids or PPIs, which will be a big part of this talk today. So proton pump inhibitors like omeprazole and lansoprazole, which can be very effective drugs. But what studies have shown is that when people start to present with reflux in the early days, they often start off with cardinal symptoms like heartburn and regurgitation. And then after being on medication for 8 weeks to 6 months, what seems to happen is that the heartburn and the regurgitation reduce somewhat, but then other symptoms start to develop. So things like bloating, flatulence, abdominal pain, and diarrhea. So whilst the original symptoms seem to die away, other symptoms develop, and then these actually become confused with reflux symptoms. So what we've been trying to do is trying to understand what the relationship is between the upper gut, the brain, and the medicines that we take. So we're going to spend quite a bit of time tonight talking about digestion and fermentation. So digestion occurs mainly in the small bowel. And the great thing that we can do to help the bugs and the microbiome in our body is to have a nice varied diet. So not too much of anything, a nice mix of fruits, vegetables, meat, eggs, nuts, grains, and not be excessive in any way. Variety is the spice of life, and that really helps us have a robust and healthy microbiome within the gut. What you can see from this slide is that there are some foods, these are the ones in green and orange, like carbohydrates and protein, that get digested quite early on in the process in the small intestine. And if you look at this blue graph across the bottom, this relates to the number of bacteria present in different regions in the small intestine all the way through to the colon. So 10 times to 3 is about 1,000 to 10,000 bacteria in the upper part of the small bowel, so not very many at all. And then as you move further down the small intestine, you get a much bigger bacterial load, so 10 to the 11 in the colon. So in this part of the proximal colon, the first part of the colon, there's huge amounts of bacteria, and they're really helpful to help us do secondary digestion of hard to break down fibers that our bodies can't digest on their own, but give us lots of nutrients, calories, and chemicals that are important for our gut health. So in the normal situation, easy to digest food gets digested up here, and the bacteria don't really interfere with that. Then the hard to digest food that goes into the lower bowel, we get that bacterial help, and that's a healthy microbial system. Now, when there's a problem, or what we call dysbiosis, so this is a disorganization of the microbiome, this can manifest in various ways. So this simple diagram just explains what happens in the normal situation. So as I said before, if you have something that's easy to digest, so an easy to digest carbohydrate like rice, this will get broken down in the small bowel, and it's fully digested before it reaches the proximal colon. But if you have poorly digestible starch like beans, then these will make their way down to the colon, and they will get broken down in the colon. And this is a perfectly healthy situation. And what you can see here is the dark green. This represents a high concentration of bacteria, and the pink is low. But if you get a condition called small intestinal bacterial overgrowth, then what you find is you get either an increased number of bacteria in the small bowel or a change in the composition of the bacteria of the small bowel. So excessive fermentation, even of simple to digest carbohydrates, starts to occur in the small bowel. And because the small bowel is small, it's very sensitive. So if this occurs in the wrong region rather than in the colon, this can produce a whole host of different symptoms. So those symptoms can be anything from abdominal pain, bloating, flatulence, altered bowel habit, nausea, skin issues. They can change, changes in bowel habit, but they can also exacerbate reflux symptoms as well. So what happens when digestion and fermentation occurs? Well, what we produce, instead of stomach acid, which is, we all know a lot about, we produce these things called short-chain fatty acids. So these are the things that make cheese smell, basically. So they're various length chain fatty acids. Some of them smell like fish, some of them like sweaty socks, and all sorts of lovely odors. But these are all perfectly naturally occurring chemicals that help maintain gut health in the colon and the small bowel, and also help things like muscle growth and energy. But we also produce gases, so things like hydrogen, sulfides, carbon dioxide, methane, and hydrogen sulfide, which is the kind of eggy smelling gas that's associated with rather unpleasant schoolboy pranks. All of these chemicals are normal, but in the wrong proportion, they can cause symptoms. We also have other things called volatile organic compounds, which are again chemicals that are normal, but in the wrong proportion can be irritant to the gut. But I want you to remember this concept of short-chain fatty acids and gas production. These are two important things that can affect reflux. So if we start with the esophagus, the first thing that we would do in a patient that comes to us is pop this beautiful little tube down. It's very gentle, very easy to pass down. Everyone tolerates it really well, he says. It just goes down the nose, into the stomach, and it sits there for about 20 minutes. And it has sensors on it that allow us to measure pressure, but it also allows us to look at liquid and gas. I'm sure some of you on the line might have had this test done before, but this is only about 2 or 3 millimeters in diameter, so much better than some of the old probes that we used to use. And the images it gives us are color images. So if we get a warm color, it's high pressure, a cool color is low pressure, purple is liquid, and blue is gas. So that should just help you look at what we're trying to show. So the first thing we're going to talk about is a symptom that doesn't respond very well to PPIs, and that's belching. So belching is, a troublesome symptom, and it doesn't increase mortality. Of course it doesn't, but it is associated with impaired quality of life. And this just gives you an example of how belching can be controlled by the brain or by the gut. So the first thing we would do is pop the tube down. The tube goes down the esophagus. And this first concept is called brain-related supragastric belching. It's a behavioral measure. It's a coping strategy to help people who have epigastric discomfort. It involves sucking air into the esophageal body and then expelling it. It can occur hundreds of times a day. Patients can often demonstrate it on demand in clinic. And there may sometimes be an underlying cause of discomfort that initiates the behavior, but it becomes deep-rooted. So how do we measure that? So this is a manometry at the beginning. So if you imagine this dotted line is the tube coming all the way down. This is your very important lower esophageal sphincter here, this band of pressure at the bottom. This is your upper esophageal sphincter, a band of pressure at the top. And when you swallow, the upper sphincter opens, the back of the tongue and pharynx pushes the bolus down, and you get this lovely coordinated contraction moving down the esophageal body and a relaxation of the sphincter. And this just shows the liquid going down at the same time. So if we overlay that, you can see liquid coming into the esophagus, going through the lower esophageal sphincter, and then being pushed down by a nice swallow. And that's normal physiology. So that's what we measure normally. But in patients who do supragastric belches, what we see is they seem to do a maneuver where they increase their pressure in their pharynx, they open up their esophageal sphincter, and this blue shows air being pushed down into the esophageal body. They then contract their stomachs and then push that back out. And they can do this repeatedly hundreds of times. So once we're doing the test in clinic and we see this type of behavior, then it's quite important to show a patient what's happening and try and show them how they can prevent that happening on a day-to-day basis. And one of the simplest ways we can do this is with diaphragmatic breathing. So here we can just see this is the lower esophageal sphincter. This red bit here is the diaphragm contracting when we do diaphragmatic breathing. And this just helps maintain really nice, strong barrier pressure at the lower end. Patient isn't doing any of the sucking in of air. And the patient can see that when this is in a nice relaxed mode and breathing deeply, then they won't do this behavior. So this is a technique called biofeedback that can look after one of the brain-related components of symptoms that persist that don't respond to PPIs. And one good trick you can do at home, and I did this last night, this picture for you, is put a pen between your teeth. So when you're practicing your diaphragmatic breathing, if you've got a pen between your teeth, then you can't suck the air in properly, and therefore you can't do the behavior. And that likewise, we always say this, if your partner's doing this and they're the frequent belcher, this is a good way to just stop them doing it while you're watching telly, put a pen between the teeth, get them to do some deep breathing, and that will help them to reduce that rather annoying but troublesome behavior. But there is also gastric belching. So this is when air is in the stomach, and this is either from swallowed with food or from carbonated drinks or products of bacterial fermentation. Everything relaxes to let that air come out. The upper esophageal sphincter relaxes, the airflow comes up, and once you've followed a belch, then you'll swallow and just clear those contents down. So it allows the gas to come out, and then any irritant contents that come up, they get expelled. And this is what it looks like, completely different pattern on our manometry. You can see that the lower sphincter pressure has disappeared here. We get equalization of pressure from the stomach all the way up to the esophagus. The blue is gas coming up from the stomach into the throat. And then, as I say here, someone swallows nicely, and then the liquid content is swallowed down. So that clears nicely. So this can happen again. It's a perfectly normal behavior, but if it happens excessively, it can be troublesome. And one question I just want you to hold in your mind is, what happens when this happens at night time when you're not swallowing? And we'll come to that in a moment. So we'll have a little pause after this next section of how we can test reflux, because this just tells us how we would objectively measure your acid reflux during a 24-hour period. So again, we put down this tiny little probe. It has pressure sensors all the way along, and then we can monitor things on this box, do symptoms on here. So it could be heartburn, chest pain, belching, food, diary entry, and whether you're lying down or going to sleep. And again, we're going to show this in the form of color rather than waveforms because it's a bit easier to see. So if we look at our supragastric belcher, here the patient has sucked the air into their esophagus, so the air is sat there. They then regurgitate the air back out, and at the same time they bring up liquid contents, and these liquid contents are acidic. They then get chest pain and regurgitation, but this is something that's been initiated by a behavioral response rather than a physiological response. So if you can get someone to reduce the amount of supragastric belching they're doing, they'll reduce the amount of acid reflux that they bring up, and this is something that they can control as part of the package of control of reducing symptoms. A proper reflux episode, as I'll call it. Here you can see the esophagus, the pH is about 6, and then when this purple liquid comes up all the way from the stomach up into the back of the, or the top of the esophagus, and then swallowed back down again, you can see the pH goes below 4, so very, very acidic, very irritant, but it's only there for a short period. But this was enough to cause heartburn in this patient. So this is what we see for a genuine reflux episode that's caused by the lower sphincter relaxing. And importantly, this has a signature of below 4, and it has this signature that's called a strongly ionic signature. So it has a resistance of 750 ohms or below, and that's because it's got hydrogen ions from the stomach acid in it. But we also get non-acidic reflux. And this is also important because simple pH testing and Bravo testing, which you may have heard of, only measures acidic reflux. Here you can see a patient has a weakly acidic reflux, so it doesn't drop into the red. Liquid still comes up into the esophagus. It causes heartburn, so they're still symptomatic. But this would be seen as a falsely negative episode if we weren't measuring with impedance. So it's important to consider non-acidic reflux as well, because that tends to be about a half to a third of all reflux events that occurs. And what about throat symptoms? So throat symptoms can be some of the most troublesome. So we can move the probe up into the throat and look at this objectively. Now, the throat tissue is much less robust than esophageal tissue. So here you've got a sensor in the back of the throat and a sensor in the esophagus. It's quite uncommon for stomach acid to come into the back of the throat. Even one episode per week is considered abnormal from healthy volunteer studies, because if acid of this strength is in your throat for any period of time, then that can be really damaging to the delicate regions. So it doesn't happen very often. If it does happen, it's likely to respond quite well to PPI therapy, But if it persists, then quite often these patients will go on to have surgery, because you don't really want this kind of stomach acid coming into your airway. But more often than not, when acid does come up with these sensors, we don't see any strong acidic changes in the throat. The acid sits in the bottom of the esophagus and gets cleared. And this is because the esophagus has many protective mechanisms to make sure the acid doesn't get near your throat. And this explains why throat symptoms really don't respond very well to PPIs. There's been several studies recently. The biggest one was something called the TOPIT trial, where patients took PPIs for persistent throat symptoms, and there was no different from placebo after 16 weeks of treatment at the 12-month follow-up. So this really showed that PPIs in a lot of people with throat symptoms are not effective at all. And this, really shows it here that currently the 18 million Americans who seek treatment for throat issues are managed by antacids. And if they're not working, there's a lot of people taking unnecessary medication. So how are we going to figure this out? I think before we move on to hydrogen and methane breath testing, which looks at some of the breath gases, there's a natural pause where people could ask a couple of questions. If you're happy for me to continue.
Any questions so far?
I can't see anyone with a hand up, and there's nothing in the chat
At the minute, so
it's
obviously enthralling, so I'll carry on.
Yeah.
So we can measure what the bacteria in the bowel is producing in terms of gas using a simple test called hydrogen and methane breath testing. So this can be done in clinic or using a home test kit. We have some test tubes, or we use breath bags. And what we do is introduce a carbohydrate, either something that's easy to digest like glucose, or sometimes more difficult to digest like lactulose. We take a baseline sample when the patient is fasted, give the substrate, and then we look at breath samples over 2 hours to see what the bacteria is producing. And this is a graph that's typical of a patient with bacterial overgrowth that we talked about before. So at the beginning of the study, when the patient is fasted, gas levels are very low. As the substrate moves through the first part of the stomach and the small bowel, there's very little bacteria there, so no gas is produced. But then as the bacteria start to produce gas, then these levels come up, and you can see here in purple, symptoms of bloating start to go up. So positive for bacterial overgrowth is about 20 parts per million rise before 90 minutes, which is this section here. And that will be considered positive for small intestinal bacterial overgrowth. So the bacteria in the small bowel are starting to interfere with your digestion of carbohydrates and starting to produce symptoms. The other gas that is associated more with bloating and constipation is methane. This tends to be consistently high at most points during the study. So even at baseline at fasted, this tends to be high. So anything above 10 parts per million associated with symptoms of bloating and constipation, then we think this bacteria and methane production is contributing to that. So that would be considered a positive test. And we'll talk about treatments in a little while. But also, once the substrate gets into the colon, we can also measure how much fermentation is going on in the colon. And anything that's above about 60 parts per million at the end of the test here would suggest that the bacteria in the colon are also producing too much gas. And you'll see the importance of that as I talk through the next couple of slides. So this is a busy slide, but don't worry about it too much. It just shows that even in healthy subjects, if you give people highly fermentable carbohydrates, so sugar called FOS, then you can induce reflux symptoms in them. So this is, an old study that we'd kind of forgotten, where healthy subjects either took a highly fermentable substance 3 times a day or placebo and then crossed over. So again, considering these are healthy subjects, what we found in this study was that the number of relaxations of the lower esophageal sphincter after a meal increased if you were having highly fermentable foods. And this curve here shows the stomach relaxing. So when the stomach relaxes, you'll get more reflux. And this was associated with increased gas coming from the colon. And it was also associated with an increased number of reflux episodes. So if you're eating highly fermentable foods, and this could be onions, garlic, certain fruits, certain fibers, then it puts a stress on the colon that then sends signals back up to the brain, and to the stomach and to the lower esophageal sphincter. So it's something that if this is happening in healthy subjects, then it's going to be even more exacerbated in patients that have a compromised lower esophageal sphincter. And we'll kind of talk through this concept as we go through of how the colon is talking to the stomach and esophagus and contributing to certain aspects of reflux. So we looked at 100 patients who were sent to us to be assessed for reflux surgery to see if there was a relationship between abnormalities in the microbiome and reflux. And what we found is that 60% of patients had an abnormal breath test, and that patients who had positive reflux symptom association for things like regurgitation had much higher gas production than those that didn't. So this was a good idea that, first of all, problems with the microbiome are common in people who are being assessed for reflux surgery. And this is important because reflux surgery is a big step. And if you can control this with some conservative measures, as opposed to surgery, then this is a good intervention. But also the commonest symptom after reflux surgery, apart from swallowing difficulties, is gas bloat. And if that gas bloat is being caused by this dysbiosis, then tackling this with either dietary or other treatments could help reflux surgery be more successful. We also found that those people that had a dysbiosis profile also had increased belching, bloating, acid exposure, and positive symptom association. So there's definitely something that's working between the lower gut and this dysbiosis and making reflux symptoms potentially worse and harder to treat. So how does that relate to what we do with our reflux testing? I realize that this is quite a difficult slide to understand, but what I wanted to show you is that what we've done now with our reflux probes, it's the same as before, is just to increase the sensitivity of the impedance measures to look at weakly ionic profiles. So things that aren't stomach acid, which we were missing before. So this is a patient asleep at night. This represents a nighttime belch. So the lower esophageal sphincter has relaxed. Contents have come up, and they've come up all the way into the back of the throat. Now, these are weakly acidic, but they can be full of irritants. So whether these are short-chain fatty acids, volatile compounds, enzymes, things like that we would normally swallow back down when we're awake, sit there for a long time at night. And we think this could be an explanation, first of all, why throat symptoms can persist even when you're on PPIs, and also why PPIs can be ineffective because they wouldn't affect this type of reflux. So these are the products of fermentation. And this is going on for a couple of hours up until, in this next slide, you can see purple up here in the throat all the way for these hours because the patient's not swallowing. And suddenly the symptoms get to a certain point where they start to swallow, clear, and then start to cough and report symptoms. So this patient's finally woken with cough symptoms and presses the event button. But this reflux is not acid reflux. It's not acid reflux coming from stomach acid secretion. It's a different kind of reflux. And I think the best analogy I can think of is it's a bit like gargling with kombucha. If you think that kombucha is full of short-chain fatty acids, it's mildly acidic, but it's not like vinegar in your throat. It's that kind of slightly irritating sensation. But if that's in your throat for a few hours, you can understand how that can lead to persistent sore throat, voice changes, hoarseness, cough, and so on. So I think we need to start thinking about this as a different kind of reflux that might be able to be treated with more conservative measures. So again, I can have a little pause here before we go on to diet. Are we okay to carry on?
No questions in the chat at the minute. Anything anybody wants to ask?
Can't see any hands up again.
No.
So everyone will have been told by their gastroenterologist or GP about things like alcohol and coffee and spicy foods and so on that generally can either relax the sphincter or cause irritation. But what we've been really interested in some of the studies that look at things like carbohydrates and high-fat meals. So we know that fat has an effect on the stomach. We know that low carbohydrate meals are easier to digest. And the evidence is still pretty scarce what it suggests here is that low carbohydrate meals, so if we think before about like things like white rice or things like nice, good quality basmati rice that's easy to digest, and vegetables, then these meals reduce acid exposure and reduce symptoms in patients. High-fat meals tend to increase acid exposure through a mechanism I'll talk about in a while. But what we don't know so far is what effect these diets have on non-acidic reflux. And there isn't much in the literature about low fermentable diets either at the moment. So just thinking about the stomach and going back to some physiology, when the stomach, well, it has three main functions. When you eat a meal, the fundus, the top part of the stomach, relaxes to accommodate that. And when you accommodate that period, the lower esophageal sphincter will tighten to try and stop that refluxing. And that tightening of the lower esophageal sphincter is also important for then the stomach to be able to pump the food downwards, grind it all up, and then empty it into the small bowel. So it's an incredibly complex mechanism, the stomach. But if you have a fatty meal, it needs extra time through this duodenal phase to be emulsified by bile so that the fat can be absorbed. So fat will slow down this phase, put more pressure on the sphincter. And I think this explains why high-fat meals can put more pressure on the sphincter and cause more reflux. So that's one thing to consider when you are having a high-fat meal, that afterwards you may want to take some preventative measures. But again, we'll talk about treatments in a moment. And we're using this very nice high-tech bit of kit now, which is a series of electrodes you can put over the stomach wall, just to show what happens in a reflux patient after a meal. So what is the effect on your gastric emptying of having a hiatus hernia? And why is it important to consider things that might additionally slow things down? So this is a normal response here. And you can see there's a little faint band of pressure here at the 3 cycles per minute range, which is normal gastric activity. And when you have a meal, this increases. So you get a nice rise in this pressure. This is the stomach working hard to grind up your meal, and then it dies away as the stomach empties. But what we tend to see in reflux patients with a hiatus hernia is they have normal activity at baseline, but it can't increase adequately after the meal, because every time the stomach tries to squeeze, then the hiatal complex, the hiatus hernia, the lower esophageal sphincter relaxes, and you get reflux. So it can't pump the food down as it would like to. And this is an analogy like with the heart. If you have a leaky heart valve, the heart won't be able to pump. And therefore, taking the pressure off the stomach during that early phase will allow that to improve. But also what improves is if you repair that hiatus hernia with surgery, then this response tends to normalize. So this is just how some high tech is allowing us to look at this in objectively in great detail. So what are we doing about it at Functional Gut? Well, we're trying to provide free and objective digestive health advice, which we'll talk about now. We're working with companies to do research to provide evidence of different approaches. We're driving new scientific advances to look at alternative causes and types of reflux, and we're using state-of-the-art technology to better understand this. So the first thing I'll signpost you to is our website called Tummy MOT. We set this up about 18 months ago, and the idea was to try and guide people through objectively through all of the truths and falsehoods about digestion and products that are being pushed, probiotics, prebiotics, supplements. So we try and give no-nonsense digestive health information and education, unbiased product reviews. So we've got over 100 product reviews. We have recipes for patients. We have blogs which have information about all sorts of things about low stomach acid and reflux and bacterial overgrowth and so forth. We also run clinical trials, so people can sign up to these clinical trials through the website and get involved in research, and that encourages companies to do research and provide evidence. And then for those people who might need a test, then they can come through to Functional Gut Clinic and explore the kind of tests that we can offer. And it's been very popular. In the first 18 months, we've had nearly 4 million views now on social media. We've had a research database of 3,000 subscribers, so 3,000 people willing to come and do clinical research, and we've had over 5,000 email subscribers with a really high engagement rate. So Tummy MOT, free website, to go and look at that, and if you do want any products reviewing or any blogs doing, then please sign up and then send us a message. In terms of conservative treatments, in terms of diet, we don't want exclusion diets, really. What you need to have is a varied diet and not too much of any one thing. So when we say low fat, it's low fat, not no fat. So a little bit of fat is good, but a high amount of fat, if you do have it, you can't control it. If you're out for a meal, then you can take some strategies like taking post-meal alginates like Gaviscon to control that. Same with carbohydrates, maybe low carbohydrate meals predominantly, and especially low in highly fermentable things like onions and garlic can be helpful, but it's not good to always avoid those things. So try and have small amounts of them if you can and if you can tolerate them. So it's all about common sense, really. Alginates we like because they don't suppress stomach acid. They seem to have some kind of prebiotic effect as well because it contains fiber, and it can be taken after meals and before bed. We don't like the Gaviscon moustache where people swig it from the bottle. You should really take this at regimented times, 3 or 4 times a day to get the maximum effect of that. Likewise with your PPIs, you take them an hour before meals to get maximum effect. Alginates are the same. You should be taking them at the right time to get maximum benefit. Now, intestinal adsorbents, digestive enzymes, I'm going to talk about in the next slide because not many people have heard about them. Pepto-Bismol is making a return. Again, it's got limitations, but in certain people it could be useful, and I will explain why. And we're also looking at how the brain can get a helping hand through a technique of vagal stimulation to reduce sensitivity, inflammation, and stress. And then if none of that's resolvable with conservative treatments, antibiotics to treat the dysbiosis can be used if the above is not successful under the guidance of a gastroenterologist. So treatment-wise, there's evidence that low fermentable diet, so this is the low FODMAP diet. So this is reducing things like fructans, which are things like onions and garlic, but also foods that are high in lactose or fructose can sometimes also be irritant to people, but you should do that under the guidance of a dietitian. Intestinal adsorbents, I'll talk about in a second. These have been developed mainly for IBS with diarrhea, where we think they have some benefit in other dysbiosis and reflux conditions. And digestive enzymes, if you do want to go out and have a meal full of garlic and onions and you know you're going to suffer, you can take these digestive enzymes like Juvia. They just give a helping hand to break down these complex carbohydrates before they get further down the system. This is a natural malt extract. So when the malt germinates, it releases huge amounts of enzymes and other peptides that seem to be beneficial for gut health and just really give a helping hand. I know my wife takes this. She's really sensitive to onions and garlic, and she takes it out in a little bottle with her if we're going for an Italian or an Indian, and just kind of takes the edge off the symptoms. So there are products that are available out there that can just be kind of like rescue medications. But I'm just going to focus a little bit on Enterus gel. This is an interesting substance that was developed really to detoxify the intestine. And it's basically a silicon-based sponge that you mix with water. So it's a tasteless gel that you mix with water. And it kind of is a bit like putting your dishwasher on a rinse cycle. It just goes through the system and then soaks up these things. And it soaks up things like bacterial toxins, inflammatory molecules, bile acids, and other sort of nasties. And, you know, whilst it was been successfully trialed in IBSD and diarrhea, and you know, we recommend this for things like traveling if you're susceptible to things like traveler's diarrhea or if you get acute diarrhea. We also use it if you have had you know, a meal where you've had, you know, maybe more alcohol than you would have normally, or more onions or fatty foods. Then an hour after eating, if you take this before bedtime as well, then it just helps to reduce that kind of bacterial load in the system. And again, it's more of a rescue medication or over-the-counter treatment that you can use just to give your bowel a little bit of soothing and cleaning, and just to help you feel a bit better in the morning. But it's certainly something that we would like to do more studies in reflux on to get some definitive evidence for. I talked about hydrogen sulfide. This is the eggy malodorous gas in your flatulence, but if it becomes excessive, then it can cause diarrhea and can cause some inflammation. So we've developed a test now to look at hydrogen sulfide. It's relatively low in sort of parts per billion range in healthy subjects, and it is increased in people with symptoms. But Pepto-Bismol, which has been around for 50 or so years, that's got a label claim for reflux and nausea and stomach irritation. The mechanism by which that works is actually to inhibit sulfur-producing bacteria, and there are studies to show this. So if you do have that kind of diarrhea predominant, smelly, flatulence type profile, then you can try a low sulfur diet, so reducing some of your protein and some of your brassicas and other sulfur containing food, or you can try short courses of Pepto-Bismol, 5 to 7 days, to see whether that can just ease the symptoms over time. But it's not really usable over the long term. So maybe when you get a flare in symptoms, then this can be a good product that you can use, and that's the mechanism by we think it works most effectively.
Anthony, quick question in the chat for you, if it's
Sure.
okay to take that. Kate's asking, the stomach acid mapping looks fascinating. How long is the patch on the stomach warm for? Can anyone use one of these, or does the clinic select patients?
Yes, sadly, it's a very kind of new technique. So it's on for about 5 hours. And basically what you do is you place the pad on the abdomen, and it measures the electrical activity coming from the stomach muscles. So when the stomach muscles are at rest, they like to contract at about 3 cycles per minute. So it's a little bit like the heart having a pacemaker at 60 or 70 beats per minute. The stomach works much more slowly, and the stomach has pacemaker cells that get this activity moving in the stomach to coordinate things. And then once you give the meal, you record for about another 4 hours. So this is pretty much only available in the private setting at the moment, in the research setting. But what we're hoping is, as we develop the evidence, as always, it takes time to then filter that down into the NHS and allow that to be available. But I think what is really helping is it's helping at the moment. Some people are having surgical treatment, either at the valve in the esophagus or in the small bowel, to alleviate symptoms, when actually that's not really the problem. So we're hoping to build that evidence to show, why this test is important, and then we can hopefully roll it out further down the line. But I think our study that we did with a company in reflux, which we're going to present in San Diego in a week or two, should really help surgeons and gastroenterologists understand why really focusing on how the stomach works is fundamental to understanding how reflux works and how treatments can work. So we're hopeful, but yes, it's like all of these things, they tend to take years to permeate through for widespread use.
Thank you.
So this is something that a colleague of mine, Adam Farmer, used in an experimental model that we had in Manchester a while ago, to show that if you put acid into the esophagus of a healthy subject, you can cause quite long-term sensitization of the nerves. But if you stimulate the ear, which is then connected to the vagus nerve, and the vagus nerve is this nerve that travels all the way through the body, has anti-pain, anti-stress, anti-inflammatory effects, then you can actually block the effect of that acid reflux causing sensitization. So when these new devices came out, for these are purchasable online, they were really not looking at gut-related issues. So we've been trialing these in a few patients now, either people with stomach issues, nausea, reflux symptoms, to see whether this can be an adjunctive therapy that can be used alongside diet, lifestyle, medication, just to really try and, if you can get 10 or 20% benefit from each of those interventions, then bringing symptoms up above a level that are troublesome, then we think these things are worth a try. So there is good evidence now looking at reduction in stress and anxiety states. And we know from the first part of the talk that stress and anxiety can exacerbate symptoms. So we're going to do some more work on this. As I say, we've done some clinical work in healthy subjects showing how this does work in acid reflux. But it's just something to have in the armory of patients when, it's a non-invasive technique. You can do this 2 or 3 times a day for about 20 minutes, and it just boosts the tone in the vagus, which has all sorts of potential health benefits further downstream. But we're trying to build more evidence around it. And then on to antibiotics. So dysbiosis, if it's chronic, and with PPIs, we know that it can lead to an increased frequency of gastroenteritis. And when you get gastroenteritis, sometimes you need some antibiotic treatment to clear out the bacterial overgrowth. So if you do have persistent symptoms and you've tried all the conservative measures, then you've had a breath test and the breath test is positive, then antibiotic treatment, specifically using a non-absorbable antibiotic that only affects the gut bacteria called rifaximin, is preferable, really. It's not widely available at the moment. But this graph just shows that if you give it empirically, then, which means you give it just on symptoms, then you don't get a great response. But if you give it with a positive breath test versus a negative breath test, you can increase its efficacy by about 30 or 40%. So rather than take an expensive antibiotic, it's probably better to get a breath test first, make sure you're sure of the diagnosis, and then that can increase the benefit of having those. There's no point taking unnecessary antibiotics, as we know. So there's, again, talk to your doctor, your gastroenterologist about this, that if you're getting bloating, distension, nausea, as well as reflux, and PPIs aren't working, then getting a simple breath test should be the next phase, and then that can guide further treatment. So the last couple of slides now, the Archimedes trial is something that we're doing with Reckitt, who make Gaviscon. And this is really an attempt to try and intercept patients early in their reflux journey to see if we can use a regimented use of Gaviscon 4 times a day, plus dietary and lifestyle advice, versus the nice standard guideline of going straight onto PPI. Then can we prevent those patients becoming over-medicalized and prevent them becoming long-term patients and reduce their reflux burden? So we're going to be recruiting for this probably in May once we have ethics. It's a fairly simple study. We'll have 30 subjects in each group. They'll be randomized to either PPI or Gaviscon and lifestyle, and then they'll be followed up for up to 6 months to see what happened to them, whether they needed to go into further medical treatment, whether they needed further diagnostic techniques, whether they developed things like small intestinal bacterial overgrowth or had that at the start, and really try and get some objective evidence to see whether there are alternative pathways you can have before going on to long-term PPIs. So just to summarize, acid reflux is well controlled by PPIs in most people, but there is a significant proportion of people where it doesn't work. I think long-term use is established now can affect the microbiome and cause related symptoms. The most common one of that is increased risk of enteric infections, but also things like bacterial overgrowth. Looking after your microbiome with diet, lifestyle, and supplements might help. So this can start tomorrow. I mean, having a more varied diet, understanding which of these highly fermentable foods can be reduced but not absolutely spared from your diet, keeping a varied diet, consider taking a probiotic or a prebiotic, just really thinking about how you can look after the rest of your gut as well as your esophagus and stomach is really important to build resilience over time. Bacterial fermentation byproducts, so the things we talked about, short-chain fatty acids and gases, can cause different types of reflux and symptoms. So if your response to PPI is inadequate, it is likely that other things may be causing or exacerbating those symptoms. So it's just something for you to consider about how you can manage those symptoms and maybe talk to your doctor about getting other tests if you need them. This type of reflux does not respond well to PPIs. So if you predominantly have throat symptoms, it's unlikely that PPIs are going to be the answer and may actually make things worse over time. So, we still need more evidence to build around this, but the evidence that PPIs don't work with throat symptoms is getting stronger. I think testing for the other causes of reflux can be helpful in guiding treatment, as we've touched on. And the questions really are, can more conservative approaches be effective in some patients early in the reflux pathway, rather than jumping onto PPIs, which then sometimes dissuade people from looking at lifestyle changes as well, because they become impervious to some of the challenges of eating some of those foods that make symptoms worse. And can those approaches really help to maintain microbiome health and diversity and make you a more resilient version of yourself going forward? I think that's something that we are working on in all our patients. So the clinical trial is upcoming to assess this, and I hope that Heartburn Cancer UK will help us to promote that trial when we start and hopefully recruit from it. That's the end of the presentation, hopefully just about on time, and happy to answer any more questions that you might have.
Thank you so much. That was fascinating, really interesting. Has anybody from the audience got any other questions that they'd like to ask Anthony? I've got one here. From Jane, with silent reflux, should PPIs be prescribed routinely? Would you recommend dietary options as a first line?
So silent reflux is an interesting one because, as we touched on, we don't really know always what's causing it. So if you've got Barrett's esophagus, then quite often you've got reduced sensitivity in the esophagus, and therefore you might be getting acid that you don't know is causing damage, and you don't feel it until you start getting swallowing difficulties. And that's really the problem of things like that phenotype. So I think, in that cause, the PPIs are definitely indicated because you've got no kind of feedback from your body that you're getting excessive amounts of reflux. If you're considering silent reflux as a different kind of reflux, whether that's non-acidic reflux or what people call volume reflux, well, what is that? I mean, is it food coming back from your stomach and therefore is it a gastric emptying issue? That's not going to be helped by PPIs. Is it reflux that's coming up through fermentation-related, belch-related, dysbiosis-related reflux? That's probably not going to be helped by PPIs either. So I think if you've got other symptoms, so bloating, nausea, altered bowel habit, frequent belching, then I think keeping taking PPIs for that is probably not a great idea in terms of it's not going to help those symptoms. It's probably going to make them worse over time. So at that point, you can say, look, my heartburn's feeling better, but this kind of silent reflux is making me feel uncomfortable. Then, I think it's been caused by something else. Can we get another test? So there's no point keep, thrashing the horse, as it were. If you throw more PPIs at something which can't be affected by it, PPIs just block one proton pump in the stomach. They don't have any other effect. So if that's not the problem, you shouldn't be treating it that way. So I would suggest that looking at other reasons, and some of the things that I suggested there, lifestyle, reducing fermentables, reducing carbohydrates, even if you do that for a few weeks, introducing some digestive enzymes, taking some enterous gel, that will give you an idea if the symptoms improve. And at that point, you could then probably escalate up and see whether more testing is needed. So you can try things that we've suggested today just to see whether that kind of reflux representation improves with some of those conservative measures.
Thank you. I hope that helps, Jane. We've got a few more questions. Is SIBO breath test available in the NHS?
Yes, it is. So it's available in secondary care from not all centres, but most centres that have GI physiology units, then you can get a hydrogen or hydrogen and methane breath test. So you'll need to be referred from your GP to a gastroenterologist. It can be somewhat of a controversial subject with some gastroenterologists who think it's either not a real thing or that you can't really treat it. You have to keep giving people antibiotics over time, which can be true. I think it can be difficult to treat in some people, but in other people, they respond to one treatment and it goes. And if you match it with some of the other conservative measures we've talked about with lifestyle changes and supplements, then you can often get a really good response to it. So it's not an easy pathway in some centres, but there's enough information out there to kind of help you navigate through the pathway. And this presentation should show you what you need to ask for if you need to go for a test. There's also lots of information on the Tummy MOT website and also Functional Gut website about the tests, what they mean, how they're actionable, and that could always be a good guide. There's also some blogs as well talking about the different treatments and symptoms.
Thank you. Sue's asking, do you have any views about using the iCoro device?
No. I kind of think that I know the guy who invented it, and it seems to be effective in some clinical trials. I don't quite understand how it's effective and how it works, so I'm still to be convinced. If people want to try it and it seems to be effective, then it's not going to do any harm, and it may be beneficial. I just haven't quite wrapped my head around how it can work effectively. But that's just me coming from a scientific rather than being opinionated about it. I just haven't used it in any patients. I've seen the reports that look like it supports it and the anecdotes that say it can help. I'm just not convinced about the mechanism. I'd like to see a bit more evidence, but that's just me being a clinical scientist rather than skeptic. So if you've tried it and it works, then keep using it because it's not going to do any damage.
Okay, thank you. What is the best probiotic you recommend?
It's an interesting one. So we've reviewed quite a lot of probiotics on Tummy MOT. So there are some companies like Simprove, Alpharex, Biocult, and a few others that have done some really good trials. Not many have been done in reflux, but certainly the way we understand how probiotics work is changing in that we don't think that they're repopulating the bacteria, in the colon or anything like that, but they contain chemicals that support good colonic health. So they produce, or they have chemicals in them that promote the beneficial bacteria we already have. Some people, when they take probiotics, if they've got bacterial overgrowth, then they can actually exacerbate symptoms. So if you do sort of feel a bit bloated, brain foggy, or whatever after a week or two of taking probiotics, it could be that those probiotics are kind of taking root in the small bowel rather than the colon and affecting those bacteria. So I think, 4 to 6 weeks for probiotics, you should see a beneficial effect. If after a couple of weeks you start to feel actually no better or actually a bit worse, then that could be due to the main problem being SIBO.
Thank you. Claire says, I was prescribed amitriptyline by my gastroenterologist for silent reflux, not sure why.
So amitriptyline is a low-dose antidepressant. So at very low doses, it doesn't really have an antidepressant effect, but it has some sensitivity effects. So basically, it's like a low-level analgesic for the gut. So it's kind of, again, if you're not really getting symptoms, it's uncertain why you would take it. But doctors like to try it as it can kind of bring your symptoms down to a level where you just kind of ignore them. They can have some side effects of slowing down stomach emptying and, dry mouth and irritability and tiredness. So they're used quite commonly in IBS. They can be effective in IBS symptoms, but they're not always very well tolerated, and they don't really get to the root cause of the problem. So, there is rationale for using them, but it's kind of masking symptoms as opposed to finding out what's really causing them.
Okay, thank you. Does acid affect the ears, as I sometimes get really bad ear pain when my reflux is bad?
This is really interesting. There's a study from Australia that looked at the type of reflux that we talked about before, where actually the reflux is mainly coming up at nighttime. It seems to be worse actually in people with constipation, because the right side of the colon, if it gets loaded and distended, then they get more of this kind of reflux that then comes up and can come higher up into the nasal passages and ears. And this guy in Australia used a technique called scintigraphy, where they imaged this kind of reflux coming up, and he treats it with laxatives, and getting rid of that bloating in the lower colon seems to reduce that kind of reflux. Not many studies on it, but I would suggest that it usually isn't stomach acid that's coming up and causing that kind of reflux pain. It's very rare. If there's any doubts, I would get a reflux test just to make sure, because if stomach acid is coming up into the throat and ears and so on, then it's pH 2, which is like 100 times stronger than vinegar. So it's quite nasty stuff. But quite often it's not that, it's just this irritating group of chemicals that's coming up and causing irritation up there. So if you do have coexistent abdominal symptoms or bloating or constipation, that might be a key to it's more of a dysbiosis related reflux rather than normal acid reflux.
Thank you. Sorry, a couple more. Hope that's okay. Or somebody agreeing with you that their gastroenterologist said the same about iPoro. And yeah, we hear about people who find it really effective. So it's a mixed bag, I think. just somebody else thanking you for a really good session. They've got to log off now, but really interesting stuff. Tina, I have a hiatus hernia. I have so many different symptoms at different times, bloating, diarrhea, cough, etc. I take omeprazole every day. So what should I start trying with the different things that have been raised tonight, please?
So, what we would normally say is at this point, then if your reflux is relatively well controlled with the PPI, but you're still getting all these other symptoms, that points to the fact that you've got this dysbiotic profile. So your digestion isn't working. The hiatus hernia, you need to control the acid reflux. So the PPI is doing its job. So you need to start considering what you can do. So if you think about this, the foods that you can eat that are easier to digest is a good starting point, because if you do have SIBO, then they're not going to get as far down in the system. So you could start off with some easy to digest rice, fish, chicken, and just see if that kind of helps with your symptoms. I think the Enterus gel product is quite a good one, because we know it works on those IBS-D type symptoms that you describe. So, that's available in, most pharmacies. It's kind of a over-the-counter or off-the-shelf medication. Take it twice a day for a couple of weeks, usually either, before bedtime and maybe an hour after breakfast. And that can just help to reduce that kind of bacterial load and dysbiosis. You can consider taking some of the digestive enzymes like Juvia, just to help digest some of those difficult to have carbohydrates early on in the process. But if those things aren't working, and they're quite often, they'll be partially beneficial in this type of profile, then getting a breath test just to see what the status is of your kind of bacterial fermentation, getting some objective evidence, and then seeing whether you might need to, have some antibiotics, and then work towards maybe coming off your PPI and managing things, off PPI, so that your stomach acid can normalize and the microbiome can sometimes normalize. If that can't work, then these are kind of patients that then go on to have anti-reflux surgery. So, if the side effects of the PPI and the bloating and the medication aren't enough to improve your quality of life, your swallowing's normal, and you've got a hiatus hernia, then they tend to be good candidates to have a hiatus hernia repaired in the long term. I know that can be quite a scary option for people.
Thank you. Seeing where I've got to, I think that was Tina's question. Helen, really interesting, thank you. I've had an oesophageectomy, so I have slightly different anatomy these days, but your advice will be very helpful in understanding and managing my gut health, which helps me manage the long-term effects of surgery. Is it worth...
We're just doing a paper at the moment, actually, with a guy called Andrew Davis at St. Thomas's, who is looking at people who've had esophagectomy and other cancerous surgery like gastrectomy, and trying to get a consensus of what the main issues are, what the tests are, and what the potential treatments are. So there is some interesting work that's going to come out quite soon that will be available to advise both clinicians and hopefully then patients and people who do the guidance, that really understand that once you change the stomach anatomy or the esophageal anatomy, then you will have some of these digestive issues, and they become a problem that can be resolved with some of the techniques and the conservative interventions we've just mentioned.
Thank you. It'll be interesting to keep up to date with that as that progresses. Is it worth doing colonic transit study in patients with constipation and reflux?
As I just touched on before, then 36% of people with reflux have constipation, so there's a definite link there compared to normal. So if you load the colon, then basically it sends signals further upstream to then relax the upper gut, and when the upper gut's relaxed, because it thinks that something might want to come back this way, so it's just normal that these areas are talking to each other. And as I say, this chap in Australia will treat people with when they treat them with laxative, shows that their constipation is better and their reflux gets better as well. So if you just think about it, right side of the colon here is full and bloated. This sends a signal to your stomach to say, get ready for something coming up potentially. Everything relaxes here and you'll get more reflux. So treating the constipation effectively should have a knock-on effect of helping your reflux.
Okay, thank you. Linda just saying, thanks from me too. Brother is going to have a esophagectomy soon, hopefully, and have a couple of friends with SIBO and on PPIs. So really interesting. Thank you. Tina, thank you so much. Found this meeting really interesting and enlightening. And Claire, just thanking you for your answer. Is there any way esophagectomy patients can get involved in current microbiome research? That's from Anne.
So I'm not aware of any active studies at the moment, but I think the conversation is definitely turning that way. So, you know, I think it's an obvious place to go, because on the one hand, a lot of clinicians, again, don't want to put people on rotating courses of antibiotics. So if there are other things that people can try to, you know, alleviate these symptoms conservatively. So just the things we talked about tonight, things like Entrust gel or some of the other intestinal adsorbents like silica gel, you know, to help clear out some of the toxins, and then, you know, to then look at the diet, varied diet, increasing microbiome diversity, you know, not necessarily overdoing PPIs if you don't need them. All those things that can promote microbiome health and resilience over time should help to sort of make symptoms go down and make things more resilient over time. At the moment, it's kind of throw PPIs at it or throw antibiotics at it, and that in the long term is why outcomes are quite poor. So if we can be a bit more centered around understanding what else can be done, like we've talked about tonight, and only making those interventions when symptoms reach a certain level. And there are some devices that are available, coming available, where you can longitudinally look at breath gases. So you can imagine a point where you reach a certain point where, say, the hydrogen level gets super high, then you can make the intervention rather than doing it all the time. And longitudinal assessment in patients with, you know, altered anatomy might be a way of intervening at the right time rather than the wrong time. So there are things abreast, and we'll keep, you know, Heartburn Cancer UK alerted to any of these things that come that might be suitable for your members.
Thank you. I think that seems to be, just make sure I'm not missing anything. I think that's all the very interesting questions. Thank you so much. That was a really fascinating talk, and I think that everybody's joined has found that too. So thank you so much for your time, and thank you everybody for joining. As ever, if you've got any topics that you particularly want us to find an expert speaker to discuss on, do let us know, and we'll do our best to oblige, because we do these on a monthly basis. So thank you all.
All right, thanks for inviting me. Thanks, everyone.
Thank you. Thanks very much.